Thank you, Deanna.
Hi, everyone. Well, I'd first like to thank Deanna Upchurch from Hope Health and Dr. Tamara McGregor from UT Southwestern for your presentations. My name is Liz Dias. I am a board member of the MSA Coalition. My connection to MSA is that my mother had confirmed MSAP and she passed away almost 5 years ago. So in October, it will be 5 years. And I will say, listening to this presentation, I wish I'd heard this 5.5 years ago, because we unfortunately did not take advantage of palliative care or hospice. My mother was in hospice for 24 hours, and that is a story for another time, quite interesting one, but I wish that I had heard this earlier. So thank you both for your work, and welcome. So I've been looking at the chat. So if anyone has questions for Deanna or Dr. McGregor, please put them in the chat. I see a few questions already, so I'll start with some of those, and then we'll keep monitoring the chat. Dr. McGregor, I think I'm going to start my questions with you. I liked how you compared palliative care to hospice and said that they were first cousins. Could you elaborate that on a little bit more for us?
Yeah, thank you for having us, especially. Thank you, Deanna, for your story, and for you, Liz, as well. When I talk to patients about palliative care in general, whether it be MSA patients, heart failure patients, cancer patients, talk about palliative care, I do two things. I say full disclosure. We need to be fully transparent about what the conversation is about. That is to make sure that we are treating you in the way that you want to be treated, help you be comfortable for as long as that may be, hopefully a long time, and to have autonomy. That is what do you want, and is what we want. So I always tell my patients that I work for you. I usually ask at the beginning of my consult, what do you understand about palliative care? Number one answer, never heard of it. Okay. So which gives me an opportunity to sort of educate about what it means. I think I put some simple definitions in my talk about, make feel better stuff we might not be able to fix. That's my West Texas answer. But it makes sense. But I ask them what they understand about palliative care. And then I often ask in the very next question, what do you understand about hospice? Because sometimes they know they're going to talk to palliative care and they Google palliative care and it says, see also hospice. And so their eyes are like this before I even get to talk to them. And I need them to understand that hospice came first. Hospice has a fantastic model. I worked 24 years nonstop with hospice, love it. But hospice idea is make sure you're as comfortable as you can be, where you want to be, surrounded by people, and have the support that you need to be comfortable at the very end. But palliative care said, well, we're jealous of that. We would like to provide that, but be able to take it backwards so that someone can be getting active cancer treatment and having terrible symptoms and not really be able to tolerate those life-prolonging therapies because they're miserable. And so palliative care, we get to get hold of them. We get to work on those symptoms that help them tolerate that life-prolonging therapy and then have it longer. And so I say they're first cousins because they are related. They're not equal. They're equally wonderful, but they're not equal and they're not the same.
Clear.
So, yeah, first cousins. It's a stupid West Texas analogy.
Yeah, it makes sense. Could be, yeah, I like it. Thank you. Looking at the other questions, maybe Deanna, this one is for you. Someone asked, is hospice no longer considered end-of-life care? I think you covered this to a bit. So.
Yeah, I think that hospice, it varies, and certainly Dr. Tamara will be able to help me with this as well. What I know that what we see in hospice services is there sometimes are people, as you said, Elizabeth, that come on and they're only on for 24 hours of care. And then there are others who, sometimes the care and the condition of the patient actually sometimes improves because of the care, because of coming off of a lot of different medications. So a patient will stay on longer. And so we've had patients that have been on, sometimes it's over 6 months, sometimes it's a year, sometimes it's a year and a half. So to say that it's end of life, I guess we would first start with, how do we define end of life, right? It doesn't mean that we're going to go on hospice, and it doesn't always mean that the person's going to die the next day or in the next weeks to months even. So hospice can have a broad range. I will say I'm on the East Coast, and our average length of stay for hospice here is less than 2 weeks. We really kind of chalk that up to a lack of education and a lack of the idea of when patients can be admitted to hospice, that they could come on earlier and have the benefits of the services longer if they did that.
Yeah, that's an interesting point about lack of education. I remember being cornered a few months before my mother died by her friends to talk about palliative care or hospice. And I think my father said, please leave the room. But I understand that lack of education. What would you do? I don't know who this question would go to, either person, but what would you do if your hospital doesn't have palliative care? So Tamara, Dr. McGregor, you had said most hospitals have it, but what if your hospital does not have it?
I mean, there are good sources, thank heavens, on the internet where you can say, find a palliative care doctor, and you can put in your zip code, and they should be able to find someone within a reasonable distance. Since pandemic, I think there's even more, virtual consultation. Someone who can usually talk to you about things that you can do. We are getting more and more Pally docs out there, but it's slow, and there's always going to be more patients that need it than people that are trained in it. And so, but I think the first thing is to ask. So if you have a physician and you say, wow, we are having a lot of symptoms, we're not, he's having a lot of trouble, we're going to the hospital more than we would like, we'd like to get some things clear. Can we speak with palliative care? Can we get it? You can self-refer to palliative care. You don't have to have a referral for it. So it's not uncommon for people to look on the internet, get a name, get my name, send me a message, and then we try to connect them with a service that's near. So it is there. It is paid for. It's Medicare B, and most of the time it's also insurance. I work at a safety net hospital for people with no insurance, and we provide palliative care there as well. So it's findable. I would say if you have trouble finding it, I put two websites at the end of my talk that you can look, but I love Google. Google palliative care near me, and you'll find it. Same with hospice, hospice.org, National Hospice and Palliative Care Organization, NHPCO is another .org. And I think it's very much like a hospice locator, but it's also hospice or Pally. So,
Clear.
Yeah.
Thank you. There was a question in the chat about voice banking. Do either of you have experience with services that do voice banking as part of your work?
I think that's a great idea. I haven't heard that phrase. I'm assuming that you record your voice with the answers and questions ahead of time.
Yeah.
I love that idea. I have, as a family doctor first, with any neurologic disorder, for me, I'm a talker. If I can't communicate, that's going to be, and when I can't communicate, it's going to be very frustrating for me. So sometimes by the time we get like an audio Vox or one of the formal voice making machines, it takes a while to get it, and then they don't get to use it for very long. Okay. And so I have gotten my phone out, and we've done little translator apps, so you can take there's a there's a translator, and you can literally record, I'm thirsty, I have an itch, I'm cold, would you bring me blank? And they're able to hit that button, and it would be like I'm talking to someone, that speaks Spanish, and I don't. But you can do it in English, and there's even a couple where you can I want a British accent. And so you can give yourself a female British accent, or you could sound like you're from Ireland, or I don't know. I try to get people to see it. They're $3, $4, no dollars. So sometimes just using translator apps just on the phone or an iPad is a cheaper, faster version. I would always say, since we don't know how quickly things will change, especially if there's already sort of some throat symptoms, assume that voice is next, and please make your wishes known. Talk to your loved ones, make some lists, do some voice banking. I think it's fantastic. I don't know the service it's at, but that's a really wonderful idea.
Clear. Thank you. Great tips. Deanna, I'm getting the note that we have to wrap up the Q&A, but I'd like to end with a question to you. As a person who's worked in hospice for 20 years and also as someone who's used the services for your family quite recently, what would be kind of the one tip for this audience that you would leave them with today?
I think it would be, let's not be too afraid to ask about these services earlier, just to know what they are, so that we have more of an understanding and kind of in our toolkit, even if we're not ready now, and even if we're not ready for a few years, that we know what they are, so that we understand when we are approached. Would you like to talk about palliative care services or hospice services? we are a little more understanding of what those services provide, because I wish we had done it sooner, to be honest.
Yeah, clear. Yeah, I like that. Have the knowledge to have it in your toolkit, and to when it comes up later, not be afraid to make decisions as you need to.
Right.
I would agree with that. Knowledge is power. Knowledge is planning.
Like that.
Talking about it doesn't mean it's going to make it head any faster, but if we don't talk about it, something happens, can't get that back, and there's time that could have been better spent more comfortably with more control and over their environment. So yeah, just bring it up. It's never too early to talk about it.
I like that. I think we're going to end on that note, that knowledge is power and knowledge is planning. So I'd like to again thank both of you, Deanna and Dr. McGregor, for joining us on this session. Loved your sessions. Hope to see you again at our conference. And to all of our audience, enjoy the rest of the conference. I hope you enjoyed this session as much as I did.
Thank you so much.
Thank you.